Usually, when we think about architects, we picture, blueprints for skyscrapers.
Right, yeah, like steel, glass, concrete.
Exactly. Clean, predictable physics. But today, our stack of sources for this deep dive looks quite different.
It really does.
Yeah, we're looking at these incredibly dense, high-stakes surgical playbooks from the world of head and neck oncology and reconstruction.
Which is fascinating.
It is. It's essentially the diary of a master architect who has to build with human tissue.
And it is a completely different kind of engineering. I mean, when you look at these procedures, treating oral and oropharyngeal cancers isn't just about, extricating a tumor.
Right.
It is fundamentally about preserving the essence of how you interact with the world.
Yeah, how you live your life.
Exactly. It's about maintaining your ability to chew, to swallow, speak, and smile. The structural margins are just razor thin, and the functional stakes are absolute.
So we are going to decode these medical playbooks today. Whether you are actively studying oncology or you're just, deeply curious about extreme human engineering, we really want to understand exactly how modern medicine tears down and rebuilds the human face.
It's an incredible process.
But I guess to understand how these surgeons reconstruct the house, we first have to understand how the fire starts, right?
Well said. Yeah, the origins of these cancers really exist in two distinct categories now.
Okay.
The traditional triggers are deeply tied to chemical exposure and localized cultural practices. For instance, in parts of Asia, the predominant oral cancer is buccal mucosa cancer.
Which affects the inner cheek, right?
Right, exactly. And this is directly linked to chewing padgeon, which is a mixture of betel leaf and oregano.
I also saw in the sources this mention of reverse smoking, which I'd never heard of before.
Oh, yeah?
Where the lit end of the cigar is actually kept inside the mouth.
Yes, it is.
And that targets the hard palate and the maxillary alveolus. And I mean, the chemistry of the damage across all these traditional triggers is just brutal.
It really is. We are talking about benzopyrenes and nitrosamines from the smoke.
And they act synergistically to damage DNA.
Yes, and at the same time, acetaldehydes are generating these localized free radicals.
So it's just a constant attack on the cells.
It is a process of chronic, repeated chemical trauma. I mean, over years and decades of this exposure, the epithelial cells lining the mouth simply cannot repair the DNA damage fast enough.
And that leads to uncontrolled replication.
Exactly.
Okay, let's unpack this a bit. So the traditional carcinogens are essentially like a sledgehammer, right? Just constantly battering the cell's DNA.
That's a good way to put it.
But the sources show there's a massive shift happening, like a bimodal peak in the demographic.
Yeah, this is huge.
You still have the older patients with the smoking-related cancers, but now there is this huge surge in younger, otherwise totally healthy individuals developing oropharyngeal cancer.
Right, specifically the base of the tongue and the tonsils.
So what's causing that spike?
That surge is driven entirely by HPV, the human papillomavirus. And it does not operate like a sledgehammer at all.
No.
No, the mechanism is incredibly insidious. The virus utilizes two specific oncoproteins, E6 and E7.
Okay, so let's unpack how those proteins actually behave inside the cell because it completely bypasses that normal trauma route we just talked about.
Right, so normally your cells rely on tumor suppressor proteins, primarily P53 and PRB. Think of them as your cell's emergency brakes. If a cell sustains genetic damage and starts replicating out of control, P53 steps in and forces the cell into apoptosis.
Which is programmed cell death.
Right, exactly. But when HPV infects the tissue, its E6 and E7 proteins physically bind to your P53 and PRB.
And they don't just block them, right? Like they actively destroy them.
Yeah, they tag those tumor suppressors with ubiquitin, which acts as a molecular barcode, basically signaling for destruction. The cell's proteasomes read that barcode and literally shred the P53 and PRB into useless amino acids.
Wow.
So the cell loses its emergency drinks entirely.
So smoking is a sledgehammer. H-Physia is more like a sophisticated computer hacker.
Exactly.
It sneaks in, avoids damaging the hardware, and just quietly uninstalls the antivirus software so the cell can't defend itself.
And that completely alters the risk profile for you as the patient. We're no longer just looking for the lifelong heavy smoker.
Right.
This hacker virus means the patient sitting in the oncology ward could easily be a 30-year-old in peak physical condition.
That is terrifying. So, okay, now that we know what triggers the tumor, let's look at how it behaves in the actual geography of the mouth. Because the floor of the mouth is flagged in the notes as a major hotspot, accounting for 18 to 33% of these cancers.
Right.
Why is that specific area so vulnerable compared to, say, I don't know, the roof of the mouth?
Well, it really comes down to a combination of gravity, fluid dynamics, and histology.
Wait, does gravity literally make the bottom of your mouth a hotspot because carcinogens just settle and pool in your saliva down there?
It actually does.
Yeah.
If you are chewing tobacco, those toxic chemicals dissolve into your saliva. Gravity pulls that carcinogenic mixture downward, where it pools at the floor of the mouth.
That makes total sense, but it's crazy to think about.
And on top of that, the mucosa on the floor of the mouth lacks a tough, keratinized outer layer.
So it's not well protected.
Right, it is delicate, highly permeable tissue sitting directly in a toxic reservoir.
Wow. So once a tumor takes root in that delicate tissue, the surgical mandate seems obsessed with one specific metric, which is DOI, or depth of invasion.
Yes, depth of invasion dictates the entire surgical strategy.
How so?
Well, a tumor might look relatively small across the surface of the mucosa, but if it penetrates downward into the underlying stroma by more than 3.5 millimeters,
Or 5 millimeters in some protocols, right?
exactly, then the physiological landscape completely changes.
But we are talking about microscopic margins here. I mean, 5 millimeters is roughly the thickness of 2 standard pennies.
It is tiny, but crossing that microscopic threshold pushes the tumor deep enough to interact with the lymphatic highways of the neck.
Oh, I see.
Beyond that depth, the risk of what we call occult metastasis spikes.
Occult meaning hidden.
Right. That means the cancer has likely already shed microscopic cells into the lymphatic system, even if the patient has no palpable lymph nodes and looks totally clear on a surface exam.
So the surgeons just have to assume the cancer has already packed its bags and started migrating.
They do. They can't just resect the primary tumor anymore. They're forced to perform an elective neck dissection.
The end.
Yes. They literally have to open up the neck and meticulously clear out the entire regional lymph node basin, because leaving even a single microscopic stray cell behind is a death sentence.
That is intense. And to map where the tumor is and where it might be hiding, they rely on something called the Warburg effect, which is a fascinating metabolic quirk of cancer cells.
It's one of the most useful things we know about cancer metabolism. Normal, healthy cells utilize aerobic metabolism. They use oxygen to efficiently generate energy.
Right.
But the Warburg effect describes how cancer cells, despite having ample oxygen available, preferentially switch to glycolysis.
So they just ferment sugar.
Exactly. They rely on inefficient sugar fermentation to power their rapid, chaotic growth.
So they are basically massive sugar addicts,
They are. They consume glucose at a rate exponentially higher than surrounding healthy tissue.
which doctors use to their advantage.
Exactly. So oncologists inject the patient with a radioactive glucose analog, fluorodeoxyglucose, and place them in a PCT scanner.
And the tumor just lights up.
Brilliantly. Because the tumor and any metastatic lymph nodes are really consuming all that radioactive sugar, they light up on the imaging, giving the surgical team a precise 3D map of the pathology.
So with that map in hand, we reach the extrication phase. And the mouth and the throat are some of the most complex real estate in the body.
Unbelievably complex.
You don't have feet of extra tissue like you do in the intestines, and yet the core mandate is uncompromising. The notes say WLE with R0 of 1 centimeter.
Right.
Wide local excision. But what does that R0 demand actually mean in practice?
So R0 means microscopically clear margins. The surgeon must remove the tumor along with a 1 centimeter boundary of completely healthy tumor-free tissue in every single three-dimensional direction.
A whole centimeter.
Yes. If the pathologist looks at the edges of the removed tissue under a microscope and finds even a single cancer cell, the margin is compromised.
Here's where it gets really interesting to me. The sources show a 71% chance of recurrence if those margins aren't clear.
It's a huge jump in risk.
So if they need a 1 centimeter clearance in a space as tight as the mouth, that's incredibly difficult. Are they essentially treating the tumor like a bomb, where you can't just cut the wires, you have to remove the entire room it's sitting in?
That is the perfect analogy. You are taking the room. For tumors involving the tongue, surgeons perform varying degrees of glossectomies, categorized from type 1 to type 5.
Okay, what's the range there?
Well, a type 1 might just involve resecting the surface mucosa, but a type 5 requires the total removal of the mobile tongue and the base of the tongue.
Oh, wow.
It's a massive resection, and the structural challenges just multiply if the tumor reaches the mandible.
The jawbone. Yeah, there is a distinction made in the notes between tumors being either erosive or invasive when they hit the bone.
Right.
What is the mechanical difference between those two behaviors?
So an erosive tumor expands as a cohesive mass.
Yeah.
It pushes a broad front against the mandible, essentially pressure washing the outer cortex of the bone away over time.
Okay, pressure washing. And invasive.
An invasive tumor is far more aggressive. It breaches the bone and sends tiny thread-like fingers deep into the porous cancellous interior of the mandible.
Oh, so it just bypasses the surface entirely.
And it often finds the internal nerve canals, like the inferior alveolar nerve, and uses them as a path of least resistance to spread straight through the core of the jaw.
That sounds like a nightmare to remove.
It is. If a tumor is just erosive, a surgeon might be able to perform a marginal resection, shaving off the affected bone layer.
Right.
But if it is invasive, you can't scrape it out. You have to perform a segmental mandibulectomy.
You remove an entire section of the jawbone.
Exactly, to achieve that R0 margin.
Which brings us to the reconstruction phase. This is the extreme human engineering part.
Yes.
Because the surgeon had to take the room along with the bomb, they now face the monumental task of rebuilding the face and mouth from scratch, leaving a patient missing half their jaw, a large portion of their tongue, and the skin of their neck.
It's a devastating defect.
So rebuilding that functionality relies on a procedure called a vascularized free flap using the fibula.
Right. The fibula is the smaller, non-weight bearing bone in your lower leg.
So what does this all mean for the patient? You wake up from jaw surgery and realize you have a piece of your leg in your face.
Basically, yes. You can remove a significant section of the fibula, and the patient will still be able to walk. But in a free flap, the surgical team isn't just harvesting bone. They take a highly specific block of tissue, the bone, a section of attached muscle, a paddle of skin, and most crucially, the peroneal artery and vein that supply blood to that exact tissue block.
How does the body even adapt to a straight leg bone suddenly functioning as a jawbone chewing food?
The geometry requires incredible precision. The surgeon takes that straight segment of fibula and makes a series of precise wedge cuts.
They score the bone.
Right, scoring the bone so it can be folded and contoured to match the natural parabolic curve of the missing mandible.
I noticed they also use a double barreling technique.
Yes, because the fibula is relatively narrow. It doesn't have the natural vertical height of a jawbone.
Oh, right.
So if they need to build a jaw that can eventually support dental implants, they will sometimes cut the fibula, fold it over on itself like a double barrel shotgun, and lock it together with titanium plates.
That is insane.
It gives the new mandible the necessary height and structural integrity. And throughout all this, they have to leave 6 to 8 centimeters of the fibula intact near the knee and near the ankle.
Oh, to ensure the patient's leg joints remain perfectly stable?
Exactly.
The structural carpentry is just incredible, but they also have to plumb this new tissue into the neck so it actually survives.
That is where the microvascular surgery comes in. They have to connect the peroneal vessels from the leg block to the facial artery with a transverse cervical artery in the neck.
Wait, how small are these vessels?
We were talking about stitching blood vessels together that are often thinner than a human hair, working entirely under a microscope.
Wow.
When they finish the anastomosis and remove the vascular clamps, blood rushes in from the neck, and that piece of leg tissue instantly comes alive in the face.
It's just brilliant. But it isn't just about the heavy bone structure either. Rebuilding the soft tissue like the lips seems terrifyingly complex.
It is one of the hardest parts.
Because you need oral continence. If your lips don't seal properly, you can't keep food, liquid, or saliva inside your mouth.
Right. The mechanics of the lips are governed by a continuous ring of muscle called the orbicularis oris.
Okay.
If you lose a small section of the lip, the tissue can often be advanced and sutured together, but if a resection takes more than 2/3 of the lower lip, primary closure is impossible without severely restricting the mouth's opening.
So they use these incredibly complex named procedures from the algorithm like the Karapanzig flap or the Abbey-Eslander flap,
The Karapanzig flap involves making semicircular incisions into the adjacent cheek tissue and rotating it inward to rebuild the lip.
rotating the cheek into the lip.
Yes. The crucial element is that the surgeon must meticulously dissect and preserve the tiny neurovascular bundles supplying that cheek tissue.
Oh, so they are moving the tissue but keeping the original nerves attached.
Exactly, so the patient retains motor control of their new lip.
And what about the Abbey-Eslander flap? I think there's also the Bernard von Barreau technique mentioned, but the Abbey-Eslander really stood out.
That is essentially a lip switch.
A lip switch.
Yeah, if a massive section of the lower lip is gone, the surgeon cuts a full thickness wedge of healthy tissue out of the upper lip, but they leave a tiny critical pedicle, a bridge of tissue containing the labial artery attached.
Okay.
They swing that upper lip wedge down 180 degrees to plug the defect in the lower lip, keeping the blood supply connected.
So wait, the upper and lower lips are physically sewn together by this bridge?
Yes, for about 3 weeks.
3 weeks.
The patient's mouth is partially sewn shut, while the transplanted tissue establishes new independent blood supply from the lower lip end.
That is wild.
Once that new vascular network takes over, the surgeon goes back in, cuts the bridge, and separates the lips again.
Just wow. And to visualize and execute all of this, they rely heavily on CAD/CAM models, right? Computer-aided design.
Oh, absolutely. They take the patient's CT scans, physically 3D print a replica of the jaw defect, and use it to pre-bend all the titanium reconstruction plates before the patient is even wheeled into the operating room.
Which must save so much time.
It shaves hours off the anesthesia time. The precision is astonishing.
But sometimes taking massive blocks of tissue just isn't viable, especially when tumors are located deep in the throat where you simply cannot cut from the outside without catastrophic collateral damage.
Right, which brings us to the technologies designed to navigate spaces they can't easily cut.
Exactly. Surgery isn't always the end of the road. Sometimes the cleanup requires lasers, robots, and radiation. How do they handle a tumor at the very back of the tongue base without splitting the jaw open?
Well, historically, to access the deep oropharynx, surgeons had to perform a mandibulotomy.
Which means?
They literally sawed the jaw in half, split the chin, and swung the mandible open like a door just to get their instruments back there.
Ah, that sounds awful.
It was very tough on the patient. But now, they use TURS, transoral robotic surgery.
So instead of splitting the jaw, they just use the natural opening of the mouth.
Precisely. A robotic unit with highly articulating, microscopic arms is driven straight through the open mouth.
Wow.
The surgeon sits at a separate console, viewing a high-definition 3D feed, and manipulates those robotic instruments to delicately dissect the tumor away from critical blood vessels and nerves.
Leaving the jaw completely intact.
Completely, yeah.
So TORUS and IMRT are basically the difference between carpet bombing the mouth and using a laser-guided drone strike to protect the local civilian infrastructure, namely the saliva glands, right?
Exactly. That targeted philosophy applies directly to the radiation protocols. There's a huge emphasis on IMRT, or intensity modulated radiation therapy, specifically for parotid staring.
The parotid glands being the ones that make saliva.
Right, they are your massive saliva producers sitting just in front of the ears. Older radiation techniques would simply blast a uniform field of radiation across the entire neck.
Collateral damage be damned.
Right, and that completely destroys the parotid glands, leading to severe, permanent xerostomia.
dry mouth, which sounds minor to some, but for a patient, it ruins their quality of life. They can't swallow dry food, they lose their sense of taste, and their teeth rapidly decay without the protective enzymes in saliva.
It's devastating. But modern oncology isn't just about keeping you alive, it's about ensuring your life remains worth living. IMRT uses computers to continuously adjust the intensity and shape of the radiation beam as the machine rotates around the patient's head.
So it paints around the healthy tissue.
Exactly. It contours the radiation field tightly around the tumor, delivering lethal doses to the cancer cells while dropping the dose down to a fraction of a millimeter right where the parotid gland sits.
That is incredible, and this entire playbook is focused on protecting functionality. Even in the precancerous stages, they throw everything at the problem conservatively before doing surgery. For instance, submucous fibrosis or SMF.
Yeah, SMF is a brutal precancerous condition, often triggered by chewing betel nut. The continuous irritation causes thick, rigid fibrotic bands to form inside the cheeks. The tissue stiffens so securely that patients eventually suffer from trismus.
Here's it.
They physically cannot open their mouths more than a few millimeters.
But before they even consider surgical intervention for that, they use a massive conservative regimen, right? I saw lycopene, interferon injections, topical steroids, and even microwave diathermy.
Yes.
How does microwave diathermy, basically deep tissue heating, actually fix fibrotic bands?
So microwave diathermy uses high-frequency electromagnetic waves to penetrate the dense fibrotic tissue and generate heat deep within the cheek muscles.
Okay.
That localized heat increases vasodilation, flooding the area with blood to clear out inflammatory mediators, and simultaneously it increases the elasticity of the collagen fibers.
So it literally warms and stretches those rigid fibrotic bands back into pliable tissue.
It does. It is a phenomenal demonstration of human resilience and medical ingenuity.
It really is. I mean, we've traced the entire battlefield today, from the way the molecular hijacking of HPV tags your tumor suppressors for cellular shredding, to mapping the metabolic greed of cancer cells with a PT scan.
It's quite a journey.
We've looked at the unforgiving physics of a 1 centimeter margin, folding a leg bone to build a jaw, and routing robotic arms down the throat to spare a patient's saliva glands.
It represents the absolute bleeding edge of what reconstructive oncology can achieve. But, when you step back and look at the broader epidemiological data within these sources, a very different kind of profound realization emerges.
Now, what realization?
There's a brief, almost hidden inclusion in the notes regarding the HPV vaccines Cervarix and Gardasil.
Oh, right. They are administered in standard 2 or 3 doses to young demographics, typically ages 9 to 26.
Exactly.
The vaccines that train the immune system to recognize and intercept the virus long before it can infect the epithelial cells.
Correct. We are facing a massive bimodal surge in highly complex oropharyngeal cancers driven almost entirely by this specific virus.
Right, the hacker.
Yeah. Yet we now possess a vaccine that reliably neutralizes the virus before those E6 and E7 oncoproteins ever get the chance to touch your DNA.
So wait, if the primary driver of this massive wave of cancer can be eliminated before the infection even begins, could there be a future where these extreme robotic surgeries and fibula-free flap reconstructions simply become obsolete?
It is a very real possibility. Will this master architectural playbook of microvascular surgery and 3D printed jawbones one day be viewed as a brilliant, heroic, but ultimately unnecessary relic of a pre-vaccine era?
Wow. We are perfecting the most aggressive, mechanically complex bodily reconstructions in medical history, but the ultimate victory over this disease might end up being a simple shot in the arm.
Exactly.
Something for you to ponder.